I know a lot of people here, but my name is Jane Harris. I'm the Director of the School of Social Work. And it's my great pleasure to welcome everybody on behalf of both the school and the Fulbright Lecture to Charles Emlet's talk today. And I think there are also some folks here from other departments, colleagues elsewhere on campus, and people in the community as well. So it's lovely to see a full room and extra chairs again, so this is brilliant. And it's also my pleasure to introduce Charles Emlet, who, as you know from the poster and everything, is a Fulbright visiting research chair in the School of Social Work for the next few months. And he comes to us from a position at the University of Washington. He's a professor of social work at the University of Washington at Tacoma. Got my emphasis right. And he brings, as the flyer also made clear to you, a very distinguished research career, a portion of which he's going to talk to us about a particular project today. But also, I think, especially for the social work folks among us, or maybe especially for the social work class that's been threaded through the audience as well, he has an interesting biography to me as well, because as he's explained to me, he's interested, very much rooted in his background in social work practice. He has an MSW from California State, I think, sometime back. But after that, worked for, I think, 20 years or more in a series of different social work practice positions, mainly in health settings, psychiatric settings, medical settings, often related to care of elderly people. And in the, seems to be in the latter part of those years, started to generate a real interest in what it was to be growing older with HIV. And with that took you into your PhD program at Case Western, I think. And since that time, he's been teaching. He teaches in numbers of areas, but including gerontological social work and health-related things, and social welfare research. And I don't want to take time today to summarize the bio that's already on the poster, but he has a very distinguished publishing and research record. And I noticed as a signal of his stature in the areas he works in, he's on the editorial board of several key journals in the area, so the Research in Gerontological Nursing, the Journal of Gerontological Social Work, and the Journal of HIV/AIDS and Social Services. And it's that piece of the work, HIV and aging, that he's bringing to us today, I think, to talk particularly about a project that he's working on currently as part of this Fulbright visiting stay. It's centered in Toronto, and it asks questions in a way that strike me as very close to social work's heart, if you like, in the sense of, if I understand it right, and we'll learn more in a minute. He's asking questions about a population of people who might, in the normal course of public talk, be seen to be somehow diminished. They're elderly, they're living with HIV, somehow diminished, maybe marginalized, really fragile, etc. And asking questions with them about what it's like to live in that way, but rather what it's like in their terms. And I think in their terms, we're going to hear much more about strength and resilience and a sense of independence in the world versus the kind of dependence that's often attributed to people in that position. So I'm looking forward to that. Thank you very much for being here, for doing this. Welcome to you. And just for logistics, we talked about expecting that Charlie would talk for maybe 50 minutes or so, and then we have plenty of time for questions and answers. So that's the plan. Welcome and thank you.
Is that working? Can you hear me? I don't want to have to yell, but these things, microphones make me nervous. So there's always a balance. Okay. Jane, thank you very much for the introduction. Yeah, for the students in the audience, you know, I teach research methods classes, and you can almost guarantee that the first day is kind of like, why are we here? Why do we have to do this? This is something to do with social work. And and it was directly from social work practice that this interest came to me in the late 1980s and early 1990s, and it hasn't stopped yet. It's the same, and my guess is it won't stop for the next 10 years or so, and then I will. But a little small but not insurmountable technology challenge. So before we get going, I'd like to acknowledge and thank Fulbright Canada for their support of my current research and this lecture today. Without the support of Fulbright Canada, I'd not be able to engage in these activities. I want to thank McMaster University and the School of Social Work for hosting my visiting research chair, and wish to thank the School of Social Work and the Gombraya Center for the Studies of Aging on sponsoring this lecture. I have numerous Canadian colleagues who have supported my research and collaborated with me examining HIV and aging in Ontario. And these include David Brennan, who is at the University of Toronto, Sarah Brennenstuhl at the University of Toronto, the Dalla School of Public Health, Trevor Hart at Ryerson University, and Sergio Arruda and Sean Rourke from the OHTN. So just want to thank all those folks for working with me and contributing to this whole process. The AIDS Memorial Quilt is for me a reminder of history, of when I began looking at the issue of aging and HIV. Today, the quilt is a powerful visual reminder of the AIDS pandemic. More than 48,000 individual 3 by 6 foot memorial panels are included in the quilt. For me, this inquiry began in the late 1980s and came directly from social work practice. Seeing older adults with AIDS who would not allow themselves to be referred to or receive services from ASOs, or AIDS service organizations, due to fear and stigma. Research can and is informed by practice, and practice is and should be informed by research. If you ever have the opportunity, see the quilt. I went online and I looked, and the closest display I could find anytime in the near future is in Scranton, New York. It's not that far away. So you can Google the Names Project for details. But the quilt is a very, very moving memorial to people who are living with and have died of AIDS. And for me, it's probably a generational thing, but I equate it to a Vietnam vet going to the wall in Washington, D.C. When we think about aging and HIV, we have to realize that we're talking about multiple populations. It's not one population, but it's a lot of different kinds of people, and they all have, and they bring to whoever is in their sphere of life a number of different issues. We have people who are at risk of HIV due to drug using and sexual behavior. No, in this, we're all talking about older people here. We have older adults receiving a late diagnosis. So people who are infected with HIV but don't know it. And they tend to be often not diagnosed for quite some period of time. And then that creates all kinds of problems that we'll talk about in a few minutes. We have people that are newly diagnosed, 50 years of age and over, with HIV. And we have long-term survivors, those aging with HIV who have been positive for 10, 20, 30 years. I started working in HIV in 1987, and I'm amazed when I interview someone who tells me they were infected before I was in the field. It amazes me, and yet I'm sitting there talking to them, and it's just, it's amazing. Okay, so before we can begin talking about aging and HIV, we need to have a conversation about aging and sex. And it's a topic that many people are not comfortable with, which is part of the problem. Our modern society is really, I think across North America, is really pretty ageist. Aging and sexuality goes undiscussed and unacknowledged. If we do manage to approach the topic of aging and sexuality, we do with jokes rather than serious conversations. It's not uncommon to turn on Jay Leno at night and hear him make some joke about older people having increased number of STIs, for example. I don't think that's funny. I like Jay Leno, I really do. I like him much better than Letterman. But I don't think that's funny. But what happens is we're not able to have a serious conversation about aging and sexuality. So it's a problem. Lindau and her colleagues did a large study of older adults and sexuality in the US a number of years ago. What they found was that 75% of people 57 to 64 were sexually active. Half of those 65 to 74 are sexually active, and a quarter of those 75 and over were sexually active. So the idea that older adults are not engaged in sexual activity, which includes sexual risk behavior, is a misnomer, it's a myth, and we have to work our way through that. All right. Kind of an incongruent picture, right? What do you see here? What's the first, when you look at this photograph, this image, what comes to mind? Somebody? All of a sudden think like you're in class. Okay. So what's this about? What's going on here? What do you see that it seems weird or incongruent, or does it make perfect sense? Yeah.
You see an older adult holding condoms, which
Yeah.
in our society, like you said earlier, that the aging population, we don't usually correlate sex with older age.
Right. Okay. So it seems a little incongruent, doesn't it? It's sort of like there's this hand and it's wrinkled. Clearly, somebody's been around a while, and they're holding condoms and they're reading sort of how-to instructions, and it's like not getting that. Yeah.
That's just what I was going to say. It looks like she's trying to teach herself how to use the condom.
Right.
I would assume that she should already know.
Yeah. So we have to be careful about assumptions, right? Interesting thing, one of the things that the literature says is that one of the things that put older women at risk is if you're in your 60s, 70s, 80s, there was no HIV. So condom use was basically around pregnancy prevention. And so the idea of condom use for postmenopausal women isn't necessarily high on the radar screen. So that's the kind of image that we need. We need those things in AIDS education and prevention materials, but we don't get them oftentimes, and we need to work on that. Okay. So it's a growing population. Just a couple of terms I'm going to talk about for a minute or two before we move forward. The idea of incidence, the number of new episodes of an illness, injury, or other health-related event that commenced during a specific time, we might think of in terms of HIV, in terms of new diagnosed cases of HIV. Prevalence, the total number of health-related states or events that exist in a specified population at a particular point in time, is more about cumulative cases of AIDS. I was teaching an HIV course last summer, and I was trying to sort of get the idea across about why this is a growing population. And let's just say for a moment that over here there's another door. The door goes outside. What used to happen was people, older adults, would become newly infected. They would come in this door. So this room represents everyone living with HIV disease, or in this case, everybody over 50 with HIV disease. But early in the epidemic, that door over there was mortality, which was really high. When I started running an AIDS project in '87, in 6 months, half our caseload would be dead. And we would have a new caseload, and then in another 6 months, they would be dead. So there was this kind of rotating thing, right? People coming in the room, and then people leaving the room. HIV infection, death. And so who was in the room was constantly changing. So antiretrovirals came along in about 1994, which is absolutely wonderful, but what's happening now is you still have a lot of people coming in the room, but there's a dramatic decrease in who's going out this door. And so the room gets fuller and fuller and fuller and fuller. According to the Public Health Agency of Canada, about 15% of all new case reports of HIV in Canada are in people 50 and over. And in the US, the CDC reports that roughly 15 to 17% of new HIV infections are in people over 50. So there's that piece, that's the new infection piece. But we also have now, because of the success of antiretroviral therapy, we have long-term survivorship. And so you can grow old with HIV disease. In fact, we don't even know how old you can get with HIV disease. We haven't found the upper limit of that. And so when we think about that, the numbers are increasing pretty dramatically because, as we said earlier, still people coming in the room. Some people have been in the room for a long time. They've been here for 20 or 30 years waiting for I don't know what. But the mortality is so diminished. Right? And so there's growing number of cases. It's a little bit harder to track in Canada because, as I understand it, the Public Health Agency of Canada does not report prevalence by age 50 and plus. So we can't really look, if you will, at cumulative numbers of people living with HIV over the age of 50 in Canada. And if I'm wrong, please let me know, because I don't want to provide misinformation, but that's my understanding. If we look, however, at some CDC data, it's pretty startling. These data are from the CDC, specific to people over 50, and they were released less than 2 weeks ago. They were released around March 1st. The slide shows the cumulative number of adults 50 and over living with HIV infection in the United States, in the 46 states that use name-based confidential reporting. By the end of 2007 to 2009, so really that's, although there's 3 years on this graph, it's really 2 years because it's end of 07 to 08 and 08 to 09. The number of people 50 and over with HIV infection in the United States rose from 211,651 to 262,595 in 2 years. It's pretty stark. So part of, when we start talking about statistics, it's very easy to get lost in those numbers and lose the people that we're talking about. And so I took a chance. There's a great website, if you get a chance to look at it. It's called The Graying of AIDS, and it's people's stories. And this is Bill Rydell. He's now 77. He was one of the first older people with HIV I met when I started working in the kind of research academic field. It was probably in the early 90s, and he's still going strong. He's still doing really well. And so he's a good example of a long-term survivor. And the nice thing, the wonderful part about Bill is he's very popular. I mean, he's all over this Graying of AIDS website, and so his story is public, and it gives us a chance to learn from him. So we can get lost in the numbers, but we have to remember these are peoples and their lives that we're talking about. The title of the talk was something like Balancing Challenges and Opportunities. So I'd like to spend some time looking at what I would suggest to you are some of the challenges of aging and HIV, as well as some of the opportunities and perhaps where we might need to be going. So I want to talk a little bit about go back to the topic of prevention in education. So ageism and myths prevent clear thinking. So that idea, going back to that image of the old woman's hand and the condoms and that kind of incongruence about I'm not getting it, you know, old people, sex, condoms, it doesn't make sense to me. To think otherwise, I would suggest to you, is ageist. To be blunt. But that ageism and those myths exist in a number of realms that are pretty problematic. First, there's denial by providers, which reduces clinical suspicion. If you don't think somebody is sexually active or you make assumptions around that, it may eliminate or reduce the thoroughness of your sexual histories that you take with clients, or it may eliminate them altogether. And I kind of call this, tongue-in-cheek, I call it grandmother transference. So you're a clinician and someone comes into your practice, and by a clinician, you could be a social worker, a nurse, a physician, doesn't matter. You're 25, 30, 35 years old, and this woman comes in, this nice older woman, and she's in her mid-70s, and you look at her and you're thinking, oh, she reminds me of my grandmother. I can't ask her questions about sex. That would be like asking my grandmother. I can't do that. And so it clouds your thinking, it clouds your clinical judgment, it impacts the way you take histories, and therefore causes potentially some problems. So, denial by providers reduces clinical suspicion. There's denials by elders. So it decreases sex practices, increases sexual risk behavior. So I have to tell you this story because it's really, really bizarre, and it makes my point. I have a colleague who runs, in the States we have these things called area agencies on aging. And they're coordination bodies that are kind of at the level of county government or sometimes bigger. And they essentially coordinate services for older adults. Well, a colleague of mine who happened to be the director of the largest area agency on aging in the States, Maricopa County, Arizona, was in the Phoenix airport. And there's this older man. You've been in airports, you're trying to kill time, and you talk to people, you might not know what. So she's talking to this guy. Now, how they got on this conversation, I don't have a clue. So she told me the story, but she never gave me the backfill of how they got to talk about this. All right. So he lives in a large retirement community in Arizona that have been called by some the new dorms. Okay. He's a handyman. So he goes around and he fixes things. He fixes washing machines, and he fixes dryers, and he fixes probably televisions, and he fixes all kinds of things. And sometimes he gets paid, and sometimes he gets paid. My drift, right? The sexual history of this guy would make all of us in this room blush. And so, being who she was, she said to him, "Aren't you worried about STIs and HIV?" And his response was, "Well, of course not, we're all old." So there's the myth. The myth not only exists with providers, it exists with older people. So, if you take nothing else away today from this talk, remember this. Your retirement check is not a condom. I don't care what you do with it. I don't care how you fold it. I don't care how you manipulate it. It's not a condom. Metaphorically, you're not at risk of HIV and STIs simply because you had your 50th or 60th or 70th birthday. So, retirement checks are not condoms. Remember that. It's really important. Okay. So, compared to their younger counterparts, older adults are more likely to have misinformation about HIV. They're less likely to get tested. They're less likely to know where to get tested, should they choose. And they're less likely than their younger counterparts to understand safe sex practices. Additionally, service providers and organizations are often uninformed about aging and HIV and may not have specific materials and programming in place. Nancy Orell, who's a sociologist at Bowling Green State University, surveyed all the state health departments across the United States, and only 30% of them had HIV prevention materials that were specific to HIV and aging. Now, we know from the public health literature that in educational materials and sort of that process of change, if you don't see yourself in those materials, you tend to dismiss the message. And so if you're an older person and everything you see in HIV prevention materials are really good-looking 25 and 30-year-olds, do you think you're going to get a sense of, oh, this is relevant to me? No, of course not. I did a survey a couple of years ago of the area agencies on aging in Washington State and found that only 16% of those area agencies on aging provided any kind of HIV education programs. So it seems to me from the time I'm spending talking to people that the ASO world, the AIDS Service Organization world, seems to be doing a better job of kind of incorporating older people into their programming than the arena of aging providers dealing with the HIV piece. I don't have any empirical evidence to support it, but it's observational. A second population of older adults impacted by HIV are those who are infected but not diagnosed. It might be due in part to low clinical suspicion of HIV symptomology, often considered issues related to aging. So it's possible that someone could come into their clinician, present a constellation of symptoms that could be HIV infection, and they are potentially dismissed because of the person's age. Older adults are much more likely to receive what's called a late diagnosis compared to their younger counterparts. A late diagnosis is defined as receiving a diagnosis of AIDS within 12 months of being found to be HIV positive. So what that means is brand new infection, HIV, way down here, AIDS, and then the complications of that. So what that means is if you're diagnosed with AIDS within 12 months of being found to be HIV positive, you're a fair ways down that spectrum, and you've probably been positive for quite some time. The issue exists across North America and can be found both in Canada and the United States. Hall analyzed data from the Public Health Agency of Canada as well as the CDC over a 10-year period from 1996 to 2005, and he found similar patterns across both countries that with older age, there's an increased likelihood of late diagnosis. He found in Canada that 69% of those over 50 fell into that category of late diagnosis. And when we look at data from the United States, we can see a very clear linear relationship. These CDC data show a strong pattern between increased age and increasing likelihood of late diagnosis. While 36% of adults in their early 30s receive a late diagnosis, this increases to 49% in those 50 to 54 and 56% in those 65 and over. The literature suggests a wide variety of reasons for this phenomenon, including lower clinical suspicion from providers, so that HIV disease is further along by the time it's diagnosed. Additionally, faster disease progression along the HIV spectrum has been found in some studies among older people. These data were released from the CDC about 2 weeks ago, and they indicate the issue of late diagnosis continues to rise after the age of 50. So among those diagnosed in the 70 to 79 age range, more than 55% receive a late diagnosis, with the highest proportion in those 85 and over, where it's about 2/3. Okay, so what's the problem? What's the big deal? It is a really big deal. When we think about late diagnosis, there's problems with increased morbidity and mortality, diminished response to antiretroviral treatment, increased health expenditures, and an increased chance of transmission to others. So if you're being diagnosed with AIDS shortly after having an HIV infection, you're more likely to have morbidity problems and comorbid problems. Your chance of death or mortality is going to increase. The sicker you are, the more diminished your response to antiretroviral treatment will be. It may not be as effective, and it's going to be more difficult to find a regime that will work for you. You're more likely to be hospitalized and need other kinds of care, so there's going to be an increase in healthcare expenditures. And probably the scariest piece of all is if you're diagnosed with AIDS within 12 months of HIV infection, you'd probably be infected for quite a long time, and there's a dramatic increase in the chance that you've transmitted HIV disease to other people without knowing it. So that's really a concern. A topic receiving increased attention is the complexity of aging and HIV processes. These can include the existence of comorbid conditions as a process of aging. Because just because you have HIV disease, you don't get a buy in all the conditions of getting old, right? There's nobody up there that says, okay, well, you have HIV, guess what? You don't get to deal with arthritis and heart disease and, chronic obstructive pulmonary disease and all those kinds of things that impact us as we grow old. There's age-associated conditions that can be exacerbated by HIV disease itself or possibly the toxicity of antiretroviral treatment, and the interesting potential phenomenon of accelerated aging. There was a study done a number of years ago called ROA, and ROA is the Research on Older Adult with HIV study that came out of New York City. And they found that over 90% of the people, and this is a very large study, this was 1,000 people over the age of 50, all living with HIV disease. More than 90% had one chronic illness besides HIV, and 77% had two or more. The colleagues that I mentioned earlier, we recently analyzed some data from the OHTN and found that about a quarter of the people over 50 in the OHTN cohort study rated their health as fair or poor. And as much as 60% of deaths among those with HIV infection are attributed to non-AIDS causes. Researchers have found the intersection of age and HIV status were statistically and significantly associated with increases in diabetes, vascular disease, liver and kidney disease, as well as depression. Rita Efros and her colleagues at UCLA note that liver disease is second only to age-related complications as a cause of death in HIV-infected patients. A research team I'm involved with in Seattle is completing analysis on a study of nearly 2,600 LGBT older adults from around the United States, and 9% of those have HIV disease. And we found significantly higher rates of cancer, cardiovascular disease, hepatitis, and poorer rated health among LGBT older adults living with HIV compared to their HIV negative counterparts. Another question associated with aging and HIV is whether HIV actually accelerates aging. It's a complex and difficult question, and certainly as a social worker, it's a bit out of my realm. But that said, there's some initial evidence that there could be some validity to this position. A researcher, Diskel Bay and colleagues, compared 245 HIV-positive individuals with 1,905 uninfected individuals from a data set, and they developed what they called a frailty phenotype. And that includes physical shrinking, exhaustion, slowness, low physical activity levels, and weakness. And what they concluded was people with HIV infection of less or equal to 4 years conferred what they're calling the frailty phenotype, comparable to an uninfected man 10 years older. So their suggestion, at least, is that there is some process of accelerated aging going on with HIV. From a slightly different perspective, Isabel Wallach from Quebec knows, she just completed a study that was published late last year, and she did in-depth interviews with older HIV positive adults from Quebec. And getting old was they said, her respondents experienced prematurely, and her respondents said they attributed it to the normal biological processes of aging, so disease and senescence, being HIV positive, and the effects of antiretroviral treatment. So it's a very complex issue that's going to need to be sorted out in the future. And there's a lot of people working on it. I'm not one. Another important area associated with aging and HIV is the potential for cognitive decline. Victor Balcour and colleagues have been studying this issue for some time through what's called the Hawaii Aging HIV Cohort Study. They use an intensive 80-minute neuropsychological battery of tests. And they said that people over 50, compared to HIV positive younger adults, had met the criteria for HIV-associated dementia nearly twice. So the people over 50 met that criteria twice as often as those under 50. They concluded that those that are HIV positive, 50 and over, had a 3.3 times greater odds of HIV-associated dementia than their younger counterparts, even after controlling for factors like education, race, substance abuse, viral load, and CD4 counts. So I want to spend a little bit of time talking about psychosocial impacts of aging and HIV, and this is where I spent a lot more of my time. I'm going to talk a little bit about disclosure, depression, stigma, disclosure, depression, and social support. So the concept of stigma emanates and originated with the work of Erving Goffman in the 1960s. And Goffman defined someone who is stigmatized as having a spoiled identity. So what he's saying is, from a societal viewpoint, if you have certain characteristics that society does not value or looks down upon, your identity is spoiled. You know, and think about that for a moment. Think about when you go, you know, you go on vacation, and you come home, and you open your refrigerator, and there's all that stuff you left. And you go and you pick it up, and it's spoiled, right? Because it's been sitting in the refrigerator for too long. And there's this sense of kind of that you move back. You don't want to touch it. You don't go, oh, good, a 2-month-old zucchini. You know, let me really begin to understand it. You pull away from it. So I think just those words of spoiled identity can be really powerful. Greg Herrick at the University of California, Davis, did pioneering work on HIV and stigma, and he defines it as the prejudice, discounting, discrediting, and discrimination that are directed at people perceived to have HIV or AIDS. Barbara Berger and her colleagues at the University of Illinois, Chicago conceptualized 4 areas of HIV stigma that fit into some broader areas of what she called enacted and felt stigma. And each individual who deals with HIV stigma will be impacted in these areas somewhat differently. Some are more personal, while others are more social. Stigma can manifest through disclosure, lack of disclosure, and the cost of keeping it to oneself. Public attitudes can also impact people's opinions of sharing a diagnosis and seeking help. Personalized stigma is conceptualized as the consequence of others knowing about your HIV. And finally, stigma can result in negative self-image through shame, guilt. The colleagues I mentioned earlier and I recently completed an analysis of data on adults 50 and over from the Ontario HIV Treatment Network cohort study. And we found that those 50 and over experienced moderate stigma on average, 46 on a range of 16 to 80. But we found some important differences by gender, sexual orientation, and other characteristics. We found that greater stigma was significantly associated with being female, being a heterosexual male, people who engage in maladaptive coping like substance abuse and denial, people with less social support, and less time since an HIV diagnosis. Wallach and Brotman in Quebec examined the lived experiences of older adults with HIV in Quebec, and they talked mostly about the fear of stigma resulting in hiding diagnosis from their children. So these are older people who are HIV positive, who out of fear of stigma are not only not telling their friends, but they're not telling their adult children, because of the potential, the perceived potentiality of being stigmatized. They also said that these individuals talked about the difficulty replenishing social networks due to HIV status. So one of the things we know from the gerontological literature is that we get older, our social networks tend to erode a bit. They get smaller. They get smaller perhaps because of death. They get smaller because of relocation. They get smaller because of perhaps our inability to adjust to that and move around. What these folks were saying, I believe, is, of course, as your social network diminishes, the ideal situation would be that you replenish it, right? That you work on adapting and finding new people to be in your social network. But they were saying the stigma, or this fear of stigma, was a huge barrier to doing that. With older people, they also have to deal with the potential issue of what is called layering. And layering is said to occur when one is a member of multiple communities who are stigmatized by society. So to try to better understand this idea of layering, I interviewed 25 older adults with HIV disease in the Pacific Northwest. I talked to each individual for 1 to 2 hours, and they shared their experiences of ageism as well as HIV stigma with me. I used in-depth qualitative interviews using a grounded theory approach. All but one person that I interviewed had experienced HIV stigma at some time in their later years, so not in their life, but in their later years. And nearly 3/4 had some experience of prejudice or discrimination due to their age. Almost 70% had experienced both. This Venn diagram gives us some illustration of how those experiences of ageism and HIV stigma come together. Because of the issue of time today, I want to just focus primarily on the 3 themes that intersect between HIV stigma and ageism. So the first one is rejection. People told me that they were rejected by their friends, by their family, by their religious community, and by service providers. One man said, it had gotten around the church that I'm HIV positive. I found myself sitting and eating a piece of cake and drinking punch on one whole aisle of chairs by myself. No one sitting next to me, no one wanting to talk to me. An older gay man said, I think most of the time they, meaning younger men, want to deal with their own people, their own age group. You know, you feel like an outcast when you're a little bit older. So that was the ageism piece. And one man, also a gay man, said, who had been dealing with HIV for a really long time, right? And he said to me, yeah, ageism is a far mightier sword than HIV. It's a pretty powerful statement. They talked about stereotyping, involving attitudes about aging and sexuality or assumptions about how people became infected. One lady said, the fact that we're 50, we're old and somebody's grandma, it can't be you. Right? That idea of how could you be? In fact, another man said to me, there's people that go, well, you're awfully old to have this disease. People talked about the experiences of feeling separate, that set them apart from society and caused them to feel alone, isolated, and separate. One man said to me, to be old and live all alone in your little mobile home, I don't have a partner, you know. I could drop dead in my house and no one might know for 3 weeks. Another man said to me, I kind of feel like I'm radioactive. So depression is another psychosocial complication of HIV disease, particularly for older adults. The ROA study, the study in New York, found that 38% of their respondents were moderately depressed and 26% were severely depressed. Data from the OHTN study, people 50 and over that we just completed, found that nearly 30% met the CESD cutoff criteria for depression. And we also found significant differences were found between women, heterosexual, and gay bi men, with gay bi men having significantly lower depression scores overall than women and straight men. And some data suggest there's a strong relationship between HIV stigma and depression, and other studies are not nearly as clear. Multiple studies, including 3 of my own, have found that older adults with HIV to be significantly more likely to live alone than their younger counterparts. It's not clear if this is due to repeated loss of partners by death, loss of family because of stigma or of the disease, or other reasons. We know from numerous studies that social support is a critical protective factor against stigma and other HIV-related issues. So, a lot of stuff that negatively impacts people's lives as they engage with HIV disease. And for, I think, a long time, we kind of stopped there and said, wow, this is really overwhelming. This is terrible. What do we do about it? But there's a flip side to this, and that's kind of where I want to end our talk today, is talking a little bit about opportunities. We need to seek out training in specific needs of HIV-positive older people, older Canadians. We need to not assume anything about sexuality and aging, rather openly assess sexual health risks with our clients and the people we work with. We need to advocate for the inclusion of HIV materials specific to older people in the aging service arenas, and advocate for appropriate policies related to education and prevention materials. In terms of health and wellness, despite the comorbidities that we've talked to and other issues, many people living with AIDS rate their health really high. In the OHTN data that we looked at over people over 50, 79% rated their health as excellent or good. Data from the Caring and Aging with Pride study in the US, we found self-efficacy and social support associated with greater health-related quality of life in 226 gay and bisexual men living with HIV. In our analysis of OHTN data, we found that gay men experience significantly less stigma than women and heterosexual men, that they had a higher mental health-related quality of life than either straight men or their female counterparts, and significantly lower scores on the Center for Epidemiological Studies depression scale. So what that tells me is what's going on there. There's something with these older gay men that are living with HIV disease. There's some kind of protective factor that isn't it important to begin to learn from them? Wouldn't it make sense to start talking to them and saying, you're doing really well, we need to understand if we can and sort of deconstruct that and find out what in the world seems to be working. We'll get to that in a minute. Protective factors against stigma. Examining HIV stigma in the OHTN study, we found several things that were protective factors against stigma. The sense of mastery, social support, non-maladaptive coping were all significantly associated with less HIV stigma. Well, what can we learn here? A couple of things that all of these things are malleable. Isn't it possible that we can have, through interventions, we can help people increase their sense of mastery and self-efficacy? We certainly can help people gain and reestablish social support networks, and we can teach people about, we know we can teach people about coping mechanisms and improving coping mechanisms. So what can we learn here? What can we learn from these folks, and how is it transferable to populations that are not doing so well? So, here's this research project, and it's called Understanding the Lived Experiences of Older Adults Living with HIV in Ontario, an Examination of Strengths and Resilience in a Vulnerable Population. Whew. Well, I can't go around saying that. I'll be out of breath all the time. So we're calling it the Aging Well study, or the Aging Well with HIV study. It's a qualitative study. It's funded by Fulbright Canada. It's been approved by the McMaster Research Ethics Board. And what we're doing is we're seeking 25 in-depth interviews with HIV-positive adults, 50 years and over, who are, by their own definition, aging well or aging successfully. And the question is, what can we learn from those who know? They know because they're living it. So what can their stories tell us and teach us about aging well with HIV? And does what we learn qualitatively match up with some of the things that we found out quantitatively, such as social support and mastery and those kinds of things being protective factors, right? So can we find some synchronicity between these methods? What does it look like in the real world? So we can hypothesize and we can think about what it means to age well with HIV disease, but in the last couple of weeks I've finished 9 qualitative interviews and I'm learning a lot. I'm learning a lot from these folks. So here's the plug. Here's my phone numbers, as well as Charles, would you wave? Stand up or something. Charles Forlot is working with me on the study. So if you know of anyone who might be interested in being interviewed, you're very welcome to call me or call Charles. Apparently our names are interchangeable. So we'll respond either way. And our goal is to complete 25 to 30 in-depth interviews with people aging well in the next, say, 3 months or so. Okay. Complex issue, as you can imagine. It's really, really complex. There's a lot to do, and it's a growing population. So what can we do? Well, we can improve our understanding of these issues. When I started working and looking at aging and HIV, I kid you not, you could take all the literature on the topic and fit it in a file folder that was about that thick. And now, if I could find everything that was written about it, I doubt I would fit it in a filing cabinet. So there's plenty of stuff. Read. Be sensitive and be caring concerning HIV and aging issues. So realizing, if nothing else, besides that your retirement check isn't a condom, maybe you don't have a retirement check, in which case, realize that this is an important and growing issue. And we need to create and support systems of help and coordination for these folks. Okay. Thanks. So the question is, what is the housing situation for people with HIV disease? Is your question concerning Canada or the U.S.?
Well, both. I mean, maybe Canada. I'm just wondering for those who are low-income brackets.
So I'm wondering if, I hate to put people on the spot, but maybe I could turn this over to some of my colleagues that know the answer to the Canadian part of the question much better. I'm not qualified to answer that question. Any, no? What's that?
We're putting in an abstract on that issue because
Okay.
that has been one of our concerns and from the Canadian context.
Yeah.
So, yeah.
In the United States, there was a program that came out of the Ryan White Care Act called HOPWA, Housing Opportunities for People with AIDS. And as we say, there ain't no red ribbons at the Academy Awards anymore. right? So it's off the radar screen, which means that this is by and large a disenfranchised population. And Hopwood, to begin with, really was a drop in the bucket, and it's also really kind of targeted oftentimes for cuts. So I think housing is a major issue. And it's not just the HIV piece, there's oftentimes comorbidity with substance abuse and psychiatric disorders, and that really, really complicates things. So I think there's a huge whole piece of HIV and housing that people spend their entire careers looking at. From the state's perspective, it's abysmal.
So when you said that that mental health were better among gay or bisexual and men, I wasn't actually surprised to hear that. I think it's because I just saw how to survive the plague last weekend, and I felt like there was probably a sense of community and accomplishment.
Yes.
And so, can you comment on any of the qualitative things you're implementing so we can try to measure that? Or would that be giving away the number?
Stay tuned. Yes, and again, 9 interviews, and it's sort of like all floating around in here, and I haven't seen or read any of the transcripts yet. But a lot of the men I talked to, out of the 9 interviews, 7 have been with men, and there is a sense of community, and an important sense of reciprocity. So most of the people I talk to are getting services, but they're doing something to give back to their community. And I think part of it is, so there's an identifiable community there of gay men or gay and bisexual men. And that sense of community and cohesion, in my opinion, doesn't exist with women, nor does it exist with straight men. And I think that part of that might be, part of the reason for that increased stigma may be sort of that internalized piece of it. That I'm somehow less of what I should have been because I have HIV disease. Good question. I'm off the hook. Oh, darn. Okay, go ahead.
I know you spoke a lot about kind of the incidence of HIV AIDS, but what are your feelings on early intervention programs in nursing homes in terms of education for people who are looking to kind of refresh their understanding of safe sex?
I think it's really important. It's also really loaded. I mean, first of all, so, we're talking about not only aging and sexuality, but we're talking, pretty old people and sexuality. And immediately everybody kind of wants to do this, talk about that, right? So it brings out a very taboo subject. At least in the States, there's a lot of nursing homes in the States are predominantly, by far and away, proprietary profit-making companies. And so there's a lot of concern not only about, well, what will people think? What will all these older people's adult children think if we have sex education in the nursing home? Oh my God, this is terrible. And yet people are sexually active, and they do develop relationships in nursing homes. There's one of my favorite non-HIV clients, his name was Earl. I'll never forget this man. His wife died. He was he would drink episodically, he'd get pancreatitis, he'd get really sick, and he'd go in the hospital. And we tried everything. We tried all kinds of interventions. We tried grief therapy. We tried, you name it, we tried it. It didn't work. He got pancreatitis. He got really sick. He went into a nursing home. And he found the love of his life, the second love of his life. The first love was the woman who died, which is why he had all this grief. He found this woman that he fell in love with. They both moved out of the nursing home. And the last time I saw him, he was lifting weights 3 or 4 times a week, had quit drinking, and was really healthy. Okay? It was a great story. those relationships happen, and to sort of say that they're not happening, I think is very short-sighted. The other thing that's really coming to play, at least in the States, is the concern of LGBT older adults and the environment in which they can receive sensitive care in their old age. And there's this huge thing about, essentially, there's so much homophobia in a lot of the nursing homes that people, they would go without. If you get a chance, see the movie Gen Silent. It is a very, very moving documentary about older LGBT adults and the aging process and their concerns and their issues of care. But for many folks, they're really worried about, and again, it's really about lifestyle and stigma and how you live your life in what's essentially kind of a public institution, right? So I think that I think it's ridiculous to suggest that we shouldn't have HIV education or literally sex education for older adults. But if people are worried about, if we do that, and our company gets a bad reputation, and, I don't know, I think a lot of the fears are ungrounded. I think it's, primarily is ageist and homophobic and all of those things, but,
Just from another vantage point, there are two very large organizations that represent the elderly, AARP in the U.S. and CARP in Canada. Are they on side about this at all? I think that may be a little relation with education.
yeah, AARP has done studies. I can't comment on CARP. AARP has done studies on aging and sexuality, at least. They've done a few publications related to HIV disease, but I don't see them really out in front in the advocacy realm around some of this, and I wonder about that. I wonder if it isn't, I don't know. I wonder if it isn't just a little bit too taboo for them to really take on as a major issue. I don't know. So I've seen it, but it's I've seen their advocacy as being what I would sort of call, like lukewarm. My opinion solely. Am I off the hook? Are we done? Okay, thank you.
Not like a very sudden off-the-hook thing. Charles, thank you. You've left a lot to think about, and you've set both a population picture of the issues about living old with HIV, but also raise what's that like on the ground and people's lived experience. And I'm really struck listening to the complexity of homophobia, racism, ageism, sexism, classism that function into there that's so complicated to understand. To understand how it works when you have somebody in front of you and you're trying to be responsible to, or something you care about, you struggle. So thank you very much. And we didn't say that there are some handouts here, we should have handed out earlier. Charles has a little bibliography for people who might want to follow up some of those points, and also another blurb about.
Yeah, there's a very, very short bibliography about some resources if you're interested in aging and HIV. Most of them are Canadian resources, but not exclusively. And the other one is a plug for the study. So, take them, share them, put them on telephone poles,